mean, she would make us go in another room when we could do it by ourselves. But my dad has just a wicked sense of humor. So do you know the product Tragicant? It's I don't know, it's not a spice, but when you look at it in a jar, it looks like nail clippings. So he used to buy it he was a pharmacist, so he'd get it through the pharmacy. And then he would just sprinkle them in different places. Where he would find. So I always think about her when I'm teaching about nails and her conversion to nail clippings. So onychomycosis. So onychia is what? The word means nail. What's mycosis?
Fungus.
Fungal. So odd word. Okay, so these are fungal infections of the nail. They're very disfiguring. I'll show you some pictures. How many of you looked at your diabetic's feet at Good Shepherd and seen them? Or seen them on other patients? Yeah, they're very disfiguring. So especially for women who like to wear open-toed shoes, those are, they're just ugly. And I think it's a lot of the reason why patients don't want to show us their feet as well. So the dermatophytes, they can be due to the Trichophyton rubrum. That is the most common dermatophyte to cause this problem. Yeast and also non-dermatophytes like mold can also. Most of our drugs that we use can hit most of them. Sometimes you'll get an atypical dermatophyte and they won't respond, but those are really the unusual ones. They're the most common cause of nail dystrophy. So when you see these nails, think dermatophytes. The toenails are more affected than fingernails because they grow slower. So the fungus can set up in that nail plate, or not the nail plate, but in the nail root or the nail matrix, and affect the nail plate to a greater extent than we see with fingers. Children can get them. Their little fingers grow faster than ours, so they don't tend to be as affected unless they've got some type of behavior that puts them more at risk. There are 3 forms of onychomycosis. Have you all talked about these? Have you done nail? Did they talk about those? You talk about DSO, WSO, and ESO. Okay, well let's talk about those. So the focus of this infection is right here in the nail bed. And the nail matrix, if it is affected, then we get a more severe form. The nail plate. Is this the right one? Or the 2? Okay.
There's like 8 mice up there.
So the nail plate and the hyponychium also can be affected. So when we treat orally, we're going after trying to get the fungus out of that nail matrix. And when we treat with topical, then we'll treat the whole nail plate and the hyponychium, and also to the sides is what will be our targets. Okay, so clinical forms. So here's distal subungual onychomycosis, DSO. This is a dream for Scrabble. Look at all the high-ranking letters that are in there. Gosh, Dr. Britton is a fiend about Scrabble. He's awful. He's awful. When he and his sister would play, we have had fights and not spoken to each other for a couple of days. He's a snob when it comes to words, so he'd love subungual. I'm sure he's used it all the time. And he and his mother know all these short little words that you can use when you're just about out of all your tiles and nothing makes sense. And they have this dictionary rule, and they call you on it all the time. If you make up a word, you lose all your points and half the tile. So that's why I'm always bringing up the name, like Lauren's name. I told her, I said, your last name, it's like D's are like 2 points apiece. So she got 3 D's. 6 points right there. Sorry, didn't mean her married name. Okay, so here you can see the This has affected the entire nail bed, and it's played out on the nail plate. These are the fingers. Then we get destruction of those nail plates, and we get these odd and contorted nail growths. Here is the white superficial onychomycosis, or WSO. If you look on the next page, it's caused by a different trichophyton agronophyte, so a little bit different bug organism. Localized to the surface of the nail plate, so a little bit different. And then we have PSO, which is mostly seen in people who have immunocompromised state. And when you see it, you should think AIDS and rule that out. A common, not very common, proximal nail fold spreads to the nail plate in the matrix. I am not going to ask you to know those separately, but I may show you pictures of them. But I'm not going to show you a picture and ask you to identify them. So our mainstay are antifungals. So we have orals and we have topicals. The orals are very potent and very powerful. And if you can use an oral agent, that would be the preferred. It's just that some people can't because their side effect profile, their interaction profiles. When you see antifungals, the red flag, if you're in color, you can see the little man holding the red flag, I think on the next page or on that same page. Always think drug interactions with the antifungals. They're huge. They cause lots of trouble when they are present with the drug that they interact with. They can make another eutoxic from the concomitant use of another drug. You can also greatly increase the antifungal concentration in the blood and lead to hepatotoxicity. So just put that one, like clarithromycin, the statins, rifampin, antifungals, anticonvulsants. If you can remember those and look them up every time, or pay attention when your program pops up and goes, you have a significant drug interaction. It's huge. Okay. So we got the orals and the topicals. We're going to talk about when to use each. If you look down through the treatment based on severity, mild to moderate, if you got less than 50% of the nail affected, then systemic or topical are an option. The more severe the nail involvement, the more you have to go with topicals, because topicals get down into that nail matrix and kill the fungus. It's just that they then exert all kinds of other peripheral or systemic effects. Local treatment for the WSO is, because it's a superficial, it's just on the nail plate, is appropriate for that. So oral therapy, gold standard. Lamisil or terbinafine is the go-to. It's the preferred. It's the number one. The backup or the alternative to it is Forinox. Both been out for a long time. And used to, we treated people for 9 months with an oral agent, up to a year. Now we've got it down to much more manageable lengths of time, so patients don't have to be on it as long. So treatment duration is important. They both have the same spectrum against rheumatophyte molds. Candida, terbinafine, not as good at, not a very common bug for onychomycosis. Treatment duration, toenails 12 weeks, fingernails 6 weeks. Cure rate's pretty good. If you look on the top of page 9, with Sporanox, they've come up with what they call pulse therapy. It's really interesting. I think it's a very good approach. What you do is you treat the patient 1 week out of a month. Okay. Give the dose twice a day for a week. Then you don't take any drug for 3 weeks, and then you repeat it the next month again for a week. So that's called pulse therapy. So that's pretty good. It's a little bit different, but you're doing the same thing in a week. So adherence is pretty good, and you're not having to take it for 8 weeks at a time. So keep that in mind. Side effects, GI is common. Again, I've told you if you ever get on that Millionaire show and they ask you the most common side effect of a drug, always say GI. Any drug can make someone sick to their stomach, nausea. But keep in mind that these drugs cause a severe hepatotoxicity. It's not very common, but it can be fatal. So respect the drug. Sporanox or itraconazole has a risk of CHF. It's a negative inotrope. So it would be, it's more likely to be in people who are already diagnosed and either not well controlled or have severe heart failure. Those people, you'll find a lot of folks. I found in primary care, most people ignored the nails. They just wouldn't, they wouldn't use the drugs. I think some of it is because the therapy is long, adherence can be poor, follow-up may not be kept. The drugs used to be expensive, so they wouldn't be covered. You have to draw a liver test, and so I think a lot of physicians, providers in family care or family practice just don't do it because of they're worried about the side effect profile. Because liver function tests often go up, and the side effect or the drug interaction potential is very high. So I bet 95% of people that I saw with onychomycosis were never treated. Never talked about treatment, never approached about treatment, ever. And the feet are easy to miss. That's why we always, in diabetes, we tell people when you go see your provider, take your shoes off because it's hard to avoid or to ignore bare feet. Okay, so in terms of drug interactions, terbinafine is very potent. The 2D6. So that's not, it's one of the main ones, but it's not the main one. It's not a 3A4, so that's good. So it's mostly the antidepressants and psychotropic agents that are in that 2D6. 3A4 is itraconazole, so those you're going to have to look up because they're just too numerous. So keep that one in mind. Rifampin, you never use rifampin without looking it up, ever. It interferes with the metabolism of almost everything, and it's potent in everything. So I always look it up. We don't use it that much anymore. We usually use it for short periods of time, except in TB. Topical agents. So when can topical? So patients are going to think, well, I'd much rather paint my toes than to have to take a pill every day. The problem with topicals is while they are effective, the length of treatment is very long. So short, 12 to 16 weeks with toenails and fingernails. With topical, it is 48 weeks, every product. So it's a long period of time to stay with. Now, there are some times where that would be appropriate. So for DSO, early stages, probably will be effective. In those other ones I've shown you, it ain't going to happen. So for these folks, I would enlist a podiatrist for help. These require, no drug is going to take care of this. Dr. Britton has told you about his patient that had the toenails that grew around. I cannot control this thing. So they're showing you where they cut the nail to break it and then to remove it. He told you, remember the man that wore the cowboy boots for a year without taking them off? I have seen it, I've never seen it pierce the skin, but I have seen them grow around and over on the other side. Just a destruction of that nail plate. Here's a partial one. Very common. Diabetic patients, they're almost always going to get it as they advance. Your older type 2s, common. So there's 3 solutions or liquids on the market. There's Jublia, You might remember it in the Super Bowl. It was the little toads that were dancing around that had the little purple helmet. That's Julia. Veticonazole. If it's got an azole on the end, it's an antifungal. So pretty good cure rate if used appropriately for the appropriate length of time. The biggest problem with this for women is that no pedicures, no fingernail polish or toenail polish. This is in kids. This is a kid that's been probably sucking their thumb or sucking their fingers. Here's some treatment with terbinafine. Here's before and after. Very good effect. Takes a while for that nail to grow out to look normal again, but it can. Here's this one I find just extremely impressive if it's true. From a complete nail destruction to a regrowth of a, you see how long it took? Over a year for it to grow back a normal nail. There's Julia. Fighting nail puppies. Okay, so with Jublia, it comes in a, I showed you a picture of it. So it has a little applicator, it's a little brush. The biggest thing is teaching patients to use it correctly, using it on the toenail surface and going underneath to hit that hyponychium is important. Here again, you see it took about a year, but a pretty good regrowth of that nail restoration. As the nail growth comes off, you can remove the diseased part, and then no to nail polish. I would have a hard time. Okay. Taboberoli is, or Caridin is just another one in this. I'm mostly giving it to you for completeness, but I want you to look at Pinlac on the top of page 10. So this is a lacquer. It's a little bit different in terms of how it's applied, kind of like clear nail polish. It's treated for the same length of time, 48 weeks. But when it's applied not only to the nail but the surrounding tissue. So it goes up on the surrounding skin, getting underneath the hyponychium, underneath as much of the nail plate as possible. It's removed once a week. And the nail kind of debrided, probably or considered the best option for kids. Even though it's a long period of time, you're not exposing them to oral agents, and it seems to stay on better because it's a lacquer instead of a solution. So keep that in mind for children. Combination therapy can be used. You can use an oral and a topical. There are not studies to guide you. It's just that has been kind of a thing people have tried. So candidates for topical therapy. So the major advantage to topical is there's no systemic side effects. Okay? So that's its in the drug interaction. So if you have somebody who you believe would be at great risk for the side effects, then you could consider topical. Or you've got a lot of drug interactions that you can't work around, you could consider topical. Now I can tell you on some of those ugly nails, you can't do anything. Very difficult on something like this. That's when I would go with specialists and find out what they had found that works best. Even though I was somewhat impressed with this, if this is true, I was impressed with that because that's a fairly destroyed nail. It requires longer treatment, so it's about 4 times as long. So you have to kind of keep that in mind as well. Not as effective as oral. So when there's contraindications to systemic, your drug-drug interactions, you want to avoid systemic therapy. In children, your nails grow fast, they're more resilient, they may do really well with topical. Okay. Questions about those? Let's go on to paronychia. Anybody ever had that? Not uncommon. So one of your objectives is what are the risk factors? So overzealous attention to your nails, manicuring them. Nail biting, thumb sucking, so you might see these in kids. Diabetes, but you're at risk for a lot of infections. And then occupations where hands are immersed in water a lot. So people are handling commercial dishwashers or couldn't think of anything else off the bat where you have your hand in water a lot. I found when I was seeing patients that I had lots of days, find out from the people you practice with what they do, because my hands just would peel and flake off from the soap. So I had lots of trouble with my hands and skin when I was seeing patients frequently. So anyway. So treatment is first, you're looking at whether it's an acute process or a chronic process. Okay, so people who've got that hand in soap or water all the time, those are likely to have the more chronic. So in acute, you look at, is there an abscess formed or not? Did y'all go over these already? Okay. They're so painful. They're painful to look at. Okay. So paronychia, what does that word mean? What's para mean?
Around?
Around the nail. A made-up word that we accept and work with. So local care, so the warm compresses to decrease the swelling. Oral antibiotic for the more advanced or the more severe. You can use a topical, so you're going to use anti-staph for the most part. Very good one on the market you'd have to write a prescription for would be the mupirocin listed there. It's generic now. They could use, if it was, you could also use Neosporin over the counter for very mild case. If it's abscess formation, would like to drain it if at all possible. And if you can get a sample of it and do a culture and susceptibility, that would be great. If you can drain it, then after you've drained it, you put them on antibiotics for, I think I put down 5 days. If you can't drain it, the abscess, then a little bit longer treatment is recommended, I think 7 to 10 days. So what antibiotic do you choose? Well, it depends on, have their fingers been in their mouth or not? Okay. So if they're not thumb suckers, if they're not nail biters, then you go with just anti-staph. So dicloxacillin is listed there, or cephalexin. If there is a low risk of MRSA. Now, if it's a higher risk of MRSA, then you could look at Bacter DS twice a day. If they've had their fingers in their mouth, then it's a whole different bug set. So here, again, it's still staph, H. influenza, beta-lactamase. I've never heard of E. coroides. Anybody? Do we have a bacteria person in here? Micro person? Have you ever heard of that bug?
I don't recall it, but I'm sure I studied at some point.
Okay. It's the only place there that I've seen it, so, but I'm not a micro by any means. Okay, so that's your acute. So just like any acute infection, the common bug, and then any factors that would affect that, which is where the fingers have been, and then choosing your antibiotics, keeping in mind MRSA or local resistant patterns to the antibiotics you're using. So for the chronic paronychia, in addition to, here we're setting up more of a chronic inflammation, so using steroids and protecting the hands. So keeping their hands as dry as possible, out of water as much as possible, wearing gloves if appropriate for whatever their occupation is very helpful. And then using the topical steroids. Could also use if tacrolimus, so another immunosuppressant or immunomodulator. If you could not use a topical steroid, you could do that. And then antibiotics if you've got an infection on top of it. So there's chronic. So it looks a lot different from the acute. Questions about those? Anything I told you that conflicted with what y'all discussed yesterday? Okay, let's go on to ingrown toenails. Anybody have an ingrown toenail now? Usually have Dr. Britton tell you some of his stories. He gets ingrown toenails. Oh, they're painful to listen to. This is when the lateral plate goes into that skin that surrounds the nail and enters the dermis. Very painful. Pain, edema, exudate, granulation tissue. Predisposing factors, poor fitting shoes. I see this a lot in diabetics. I don't know if it's probably because of the distortion of that nail. Over time, that nail will form more of a C shape, and it will just pinch in that skin. And so I saw a lot of ingrown toenails in diabetics. Excessive trimming of the lateral nail plates, why we teach patients how to trim their nails, not trimming them down too low, trimming them straight across, and it's one of the ways that we're going to treat them when we get to that. Trauma, pincer nail deformity, which is what you see there on, it's on my right, on your right as well. Okay, so moderate to mild to moderate lesions. Conservative treatment. Did you all talk about treating an ingrown toenail? Okay, so what they are recommending, I told you about the, when I was in the VA, I was next door to a PA, and she had taken care of diabetics for a long time. And I learned a lot from her, and she taught me how to do this, so this is what we would do for our veterans. Is what we do is lift that nail plate up, and the way we would do it is we would just keep lifting the nail up, and we would insert cotton, or they say dental floss, I could see where that would work, and we would lift it up enough, and if we could leave it there, the plate would grow out over that. And we could even teach the patients, because most of our patients lived a long way away. So soaking the foot, getting it softened up, and then just lifting that nail. It sounds, I see some of you grimacing, but I can tell you it worked in a lot of people. Anybody done this? So how,
My husband did it, but
okay, so you've seen it done, right?
I did it because I was a point dancer.
So is that a part of the fallout is ingrown toenails?
Yeah.
Mm.
Broken toes.
So let's see, I've listed it down there. Soaking the foot 3 times a day, pushing away that's another thing, is once that skin gets softened up, if you can teach the patients to kind of gently push that skin to the side, that often will help as well. Remember what Epsom salts are? What are they? Chemical makeup?
Magnesium sulfate.
Magnesium sulfate. You could also use a corticosteroid just for the inflammation, if that for patient comfort, if you would like as well. Most patients will respond to this if you get it early enough. Yes.
So we had a podiatrist guest lecture about 3 weeks ago.
Oh, you did. Okay.
And he talked about how he took care of ingrown toenails. He just kind of clipped it about 2 to 3 millimeters on each side, and I think he just kind of lifted it out, and that's all he did. So he kind of like just, I guess, shortened the nail plate.
Did he destroy the nail plate on either side?
He just clipped like 2 to 3 millimeters of the nail. He didn't completely take it off. He just kind of took care of the ingrown portion of the toe.
Oh, interesting. Okay. I have seen podiatrists also just destroy the nail bed on either side, so that you just have a more narrow nail.
And I think he put some sort of solution on it to kind of help, like, keep the nail as is and not have it grow back again.
So was he addressing primarily that pincer deformity? Was he talking about doing it
Yeah.
mostly there?
Mhm.
Did he talk about what he did he probably doesn't see acute ones like that, I would imagine.
I think it was for the infected one. Yeah.
For the infected one? Very good. Anything else he had to,
I don't think I remember, but I remember that he said that that was also an option to take care of that way.
okay, so if you had to treat, again, thinking about skin flora, you would go after an anti-staph, so that mupirocin is another good one. It's really a great, it's an ointment, very good. Okay, sounds like you've had good coverage of that. Melasma, has anybody covered melasma? So you often see melasma in pregnancy. They call it, it's been called the mask of pregnancy. Women get this discoloration on their face. Women who take birth control pills, the older generation of pills, higher doses of estrogen, used to see when women would start them and go out in the sun, they would also develop on forehead and cheeks. So it's mostly affecting that upper layer of the skin. Here are common, if you've not seen it before, or you've seen it but not known what it is, this is pretty common. Forehead, cheeks, you see it here on her upper lip. So depending on how much of the dermis is affected, you'll get changes in color. So the lighter color, usually it's a more superficial damage. The deeper the damage, you can get a grayish blue coloration to the skin. There's all kinds of different patterns. So there's the central facial in there, cheeks, foreheads, lips, nose, chin, malar across the nose and the cheeks. Or the mandibular along the jawline. So photoprotection, really important, so the use of a comprehensive or broad spectrum, gosh, I can't think, sunscreen. So the SPF 30 or higher is important. One of the reason I brought it in was because of women's tendency or request for sun lightening products, and those are listed there for you. So hydroquinone, azelaic acid, we talked about that with rosacea, mequinol, and kojic acid. All of these are ingredients or products that people will use for skin lightening. Some of them are over the counter. You'll see, like with age spots, as people get older, sometimes they'll use those products as well. Retinoids can be used for more advanced cases. That can be used in combination with some of these products. There is a combination topical that is available as well. So if you look at this woman, she has undergone treatment. Well, she has too. So you see before and after. So it's very impressive what these products can do. And here's another young woman who's undergone from here and here. And so I bring them up as if your patients complain and they want treatment. It's available. It may not be something you do, or it's something you could for more, I'd say, select cases. And then the last thing that women can undergo, or I don't know why I'm saying women, men could do this too, is a chemical peel. And there's 3 different types, I think I listed. There's superficial, medium, depth, and deep. Superficial peels use glycolic acid and salicylic acid, so a keratolytic agents to remove that top layer and then let it usually have a reaction, and then the skin remodels itself. I'm amazed at people who undergo chemical peels. I've never done it, but I had a coworker who did it one time. It's so dramatic. I'm just amazed that people can tolerate it, I guess is more than one thing. Questions about these? Mostly just want to make you aware of treatments that are out there. Biggest side effects are going to be contact dermatitis, skin irritation. Okay, that's all I have, so I will see you tomorrow. Some of